Good afternoon, everyone, and welcome. My name is Anuya, and I'm the chair of the EMCR committee. So it is my great pleasure to welcome you to today's webinar. Thank you all for taking the time to join us from across Australia and around the world. I do know for some of you there might be a bit of a time difference, so thank you so much for joining in. Really appreciate it. So before we begin, I'm going to quickly acknowledge our EMCR committee. As you can see, we have quite a few members who are representing from a range of diverse backgrounds and expertise. So our mission of the EMCR committee is to promote, support, and engage with as many EMCRs as possible. This is to help shape the future generation of sarcopenia and frailty research. So if you are interested in more information about this, please use the link that is provided at the bottom of the slide. So we have a strong program planned for today, and we're featuring 3 excellent speakers who will share their expertise and latest research. So each presentation will also be followed by time for discussion and questions. But I'm just going to quickly take you through some housekeeping points before we begin. Please do keep your microphones muted throughout the webinar. You are welcome to submit any questions you have at any time using the Q&A function, and we will try to address as many as possible during the discussion periods. So without further ado, I would like to now invite Dr. Jennifer Jones to deliver the opening address. Thank you.
Thank you, Anuha, and thank you to the Early and Mid-Career Clinicians and Researchers Committee for your initiative in organising this World Sarcopenia Day webinar. We have an impressive program of international speakers, and these international collaborations and connections are so important, especially as we work to increase the awareness of sarcopenia, including its prevention and management, with World Sarcopenia Day approaching on the 4th of July. It's from these international and multidisciplinary connections, like today's webinar, which range from basic science, clinical research, and translation to practice, that the field of sarcopenia research continues to thrive. And progressing the field it's very important in the muscle and functional well-being of people living with sarcopenia. I'll end my address with a heartfelt thank you to the health professionals who have made the time today to attend. Thank you for your hard work and dedication to evidence-based practice on the clinical frontline. All of your efforts are valued in making the lives better for your patients in both the prevention and management of sarcopenia. I'll now go to the next slide where we have a membership special. So you can join our society, so the Australian New Zealand Society for Sarcopenia and Frailty Research, and we're offering a 15% discount. So you can use the code that's on the slide, and that'll be available for a month until the end of July. So a little bit about our society. We're the peak professional society specialising in the study of sarcopenia and frailty in Australia and New Zealand. And we promote and enhance excellence in sarcopenia and frailty research. We promote translational research and facilitate professional development of healthcare professionals and create awareness. So membership is key. And some of the benefits of being a member is networking. So I've been really fortunate through being involved with the society and then with the early mid-career committee, and then now on council, is fabulous professional networking. And I highly encourage you to engage with the society, particularly if you have interest in sarcopenia and frailty research. As you can see from our impressive lineup of speakers, we have international connections, but we are also an international society because we're both Australia and New Zealand. And there are opportunities once you're a member to be involved in committees such as the Early and Mid-Career Committee, and there are a number of council positions as well. So I encourage you to go to the website and take advantage of this special offer. Oh, and now I'll hand to Ju, who will introduce our first speaker.
Thanks, Jen. Good afternoon, everyone. It's my great pleasure to introduce the first speaker of our webinar today, that is Professor Nicole Kiss. Nicole is the Deputy Director and a Professor of Dietetics in the Institute of Physical Activity and Nutrition at Deakin University. She also co-leads the Exercise and Nutrition for Cancer Research Group at IPAN. Nicole has received more than $18 million in competitive research funding and is the lead investigator for the EPICS program, which stands for Establishing Pathways to Improved Care for Cancer-Related Sarcopenia. And today, Nicole will be talking to us on the title, Improving Identification and Access to Care for Cancer-Related Sarcopenia. What a great way to start the webinar. Over to you, Nicole.
Thank you, Dee. Just share my slides. Can I just check that you can see those okay? Great. And thank you very much for inviting me to present today on this topic as well. It's an area that I'm very passionate about at the moment. So just to get you started, cancer-related muscle loss is quite different to what we see occurring in aging. So cancer-related muscle loss develops up to 10 times faster than age-related muscle loss. And what we can see is that over the course of a 12-month period, which could encompass various different cycles of chemotherapy, the extent of muscle loss that we can observe often is equivalent to around 30 years of aging. So it can really leave people in significant functional deficit and quite physically declined. What we also see is that this then leads to dose-limiting treatment toxicities, particularly for chemotherapy treatment, and really restricts the ability of oncologists to prescribe and maintain an optimal dose of chemotherapy that's required for the best possible survival outcomes. And we see in people that experience cancer-related muscle loss or who have low muscle mass, there's an up to 2 times higher risk of mortality. And really importantly, this affects as many as 1 in 3 people with cancer. So it's very prevalent. Now, I'm probably talking to the converted here, but just in terms of cancer, we often see a bit of a conflation of terms. So as everyone I'm sure already understands, sarcopenia is age or disease-related loss of muscle mass and decline in strength and function. When we see the term sarcopenia quite often in the oncology literature, what is actually being referred to is low muscle mass. So muscle mass that is lower than average for age and sex when adjusted for body size. So I will be using the terms appropriately or correctly during the presentation, but some of the studies that I'll show you actually use the term sarcopenia when they're actually referring to low muscle mass. So one of the things that's really critical to understand is that there is appropriate treatment for muscle loss in terms of preventing or treating it when it occurs in people going through cancer treatment. So nutrition and exercise are core therapies for it. And what we have seen internationally is for malnutrition, which is a related condition to low muscle mass, that when appropriate screening and access to treatment is enabled, it can save around $800,000 per 100,000 people in the population, as well as improving quality of life and treatment completion for people going through cancer treatment. But at the moment, we don't have an easy way to identify people with cancer-related muscle loss, and we need to improve access to screening and facilitate access to appropriate care. So one of the first steps is screening using a validated tool for identifying either low muscle mass or sarcopenia in people going through cancer treatment. And this is really critical to facilitate referral for further assessment and then intervention. And in cancer, what we see is that identifying muscle loss when it's occurring is as early as possible after diagnosis is critical, because we really need to maximise that opportunity to improve both nutritional status and functional status. And the infographic that I've got here on the screen is from the Clinical Oncology Society of Australia. So we have a position statement on cancer-related malnutrition and sarcopenia, with some guidance for the steps of going through screening, assessment and treatment, as well as some of the tools that we are currently recommending people use for these specific steps. One of the things I wanted to point out as well is what we see at the moment in people going through cancer treatment is a masking of low muscle mass. So it's certainly not something that is obvious in all patients. And I wanted to just tell you about this study, an observational study in nearly 2,000 patients who had stage 1 to stage 3 colorectal cancer who were treated with surgical resection. And the study looked at muscle mass using computed tomography, and they also looked at weight when they assessed weight at diagnosis and then after a 15-month follow-up period. And what they found is that even in patients who were weight stable, so there was no underlying loss of weight occurring, 1 in 8 of those patients were developing incident sarcopenia. In this case, we're referring to low muscle mass. And what you can see, the images on the screen are the 3rd lumbar vertebrae from images from computed tomography. We see that people with identical BMIs can have quite substantially different underlying muscle mass as well. So the image on the top is someone whose muscle mass is within a normal range, while the image at the bottom is someone whose muscle mass is severely depleted. But with an identical BMI, this can often be hard to determine without screening or assessment occurring. So we really see that both BMI and weight stability can mask that underlying depletion in muscle mass. And unfortunately, weight and BMI are fairly common clinical indicators that are monitored and observed in oncology clinical practice. So I want to just touch on a little bit more about screening for low muscle mass and sarcopenia then specifically in people with cancer. So one of the challenges we have is really identifying both sarcopenia and low muscle mass. We don't currently have a screening tool that works or performs very well at doing this. So I just want to show you a couple of examples here. So screening tools for malnutrition, and while malnutrition is a very distinct clinical condition, it does have a component of muscle loss as part of a malnutrition diagnosis. So people have looked to see whether these malnutrition screening tools are able to identify people with low muscle mass. And what we've found is that screening tools that are commonly used, such as the Malnutrition Universal Screening Tool or MUST, as well as the MST, are classifying anywhere from 40 to 45% of people who actually have low muscle mass as not at risk using those screening tools. And it's partially because these screening tools focus on things like unintentional weight loss, reduced food intake or appetite, and body mass index. And as we've just seen, these things can often mask muscle loss as well. Then also screening tools for sarcopenia, and they haven't been explored in detail in patients with cancer or in oncology populations, but I'm sure everyone listening today is well aware of the SARC-F questionnaire as a screening tool for sarcopenia. And it's something that has been more increasingly used in oncology populations. But one of the things we find is with the questions that consist of the SARC-F, they're not very sensitive to the type of muscle loss that occurs in people going through cancer treatment. So it's a tool that's really been designed for age-related muscle loss and sarcopenia. The rapid muscle loss that occurs in someone going through cancer treatment is not really well captured through this type of screening tool. And we can see that in studies that have shown the sensitivity of the SARC-F in detecting low muscle mass. In this particular study, again, it's been called sarcopenia. It's actually referring to low muscle mass. So this study was in just over 300 people who were going through treatment for lung or gastrointestinal cancer. And the authors looked at the ability of the SARC-F as well as the SARC-F with calf circumference to be used as a screening tool for low muscle mass. And this was identified using CT imaging. When the Sarcef alone was used, there was only a sensitivity of around 15%. Specificity was higher, so the tool was good at ruling out people who didn't have low muscle mass, but was very poor at identifying the people who did have low muscle mass. And the sensitivity was increased with the use of calf circumference, but still less than 50% overall. So really meaning using this screening tool, people with low muscle mass are being missed. And I just want to highlight some work. One of my current PhD students, Natalie Tan, is completing a scoping review at the moment. It's not yet published. It will be submitted shortly, but she's been looking at the diagnostic performance of screening tools that are currently used for either malnutrition or sarcopenia in any population, but how well they are able to identify low muscle mass in adults with cancer. And there really isn't a lot of studies out there. So 4 studies were included in this scoping review that looked at 5 different screening tools. So the Malnutrition Universal Screening Tool, MST, the Nutrition Risk Index, Sarcef, and the Sarcef with calf circumference. And a couple of those studies are the ones that I've just shown you on previous slides. So really what was found overall is that all of these tools demonstrated poor diagnostic performance in detecting low muscle mass in people with cancer. So that takes me to the EPICS program. So as you were told in the introduction, this is the Establishing Pathways to Improve Care for Cancer-Related Sarcopenia, or EPICS program. It's one of my main projects at the moment. And I've got a wonderful project manager, Dr. Annie Curtis, who's there on the screen, who's working very closely with me on this piece of work as well. So what we're doing with the EPICS program is developing a screening tool for cancer-related sarcopenia or low muscle mass. So the idea or overall aim is to deliver a validated, short and simple screening tool for cancer-related low muscle mass, as well as integrating it into clinical practice across health services and policy. And I will step you through the various stages of work that we're going through, but this is a broad overview of the program at the moment. So we are in the development stage at the moment. We are developing the screening tool, also doing some work to support future implementation of the screening tool. And in the final 2 years of the program, we will be embedding the tool within health services and within national oncology guidelines. And I'll talk to you a bit more about each of those pieces of work now. So this is where we are at the moment, just at the end of this development stage. So if we start with development of the screening tool, we've taken a evidence-based and stepwise approach to creating this tool. So the first step was really to undertake a comprehensive review of the literature. So we did a scoping review that looked at routinely assessed clinical measures that were associated with low muscle mass or muscle loss in people going through cancer treatment. There were almost 300 studies included in that scoping review, and within those studies, 20 factors that were associated with cancer-related low muscle mass or muscle loss were identified. What we found, so these are the 20 factors. The ones that are in bold are the ones that we found were very consistently associated. So there was little variation across the literature. These ones were found to be associated consistently across the various different studies. So what we then did was take those 20 predictors that we had identified and we took them to a Delphi study with international experts in cancer-related muscle loss. And we were wanting to get consensus on which of those 20 predictors were critical or important for us to consider in a screening tool for cancer-related muscle loss. In that Delphi study, we then asked the experts also on the operationalisation of those factors into screening tool question format. And we also then took those questions once they were developed to consumers and health professionals who would either be receiving the tool or using the tool with patients and undertook feasibility testing to refine those So we had around 30 international experts participate in the Delphi study, and 17 health professionals and people with cancer complete the face validity testing. What we ended up from this Delphi process and face validity testing was with 16 possible screening tool questions that represented 15 predictors that we'd found in the literature. And these are the 15 factors that were deemed to be critical or important to include in a screening tool. So this is just an example of some of the questions. I'm just asking not to take any screenshots or photos because we're just in the process of trying to publish this piece of work at the moment. But these are some of the example questions. So as I mentioned, there are 16 potential questions. What we are doing next is validating these questions. So we've taken those 16 questions and we've asked them of patients. We've been collecting CT scans and assessing muscle mass on those CT scans as our reference method. And we'll be looking at the optimal set of questions that have the highest sensitivity and specificity to identify low muscle mass. And those questions will form our final screening tool. So we're just about to commence the analysis for this shortly. So hopefully we will have a screening tool to share and publish with people very soon. So in this validation study, we had 615 people with cancer participate. The other component of the program that we've been doing at the moment is to really do a lot of work to support implementation of screening and improve people's access to evidence-based care for cancer-related low muscle mass. So one of the pieces of work we undertook to prepare for implementing this screening tool within clinical settings is to understand how screening tools have been implemented previously and what has worked and what hasn't worked in hospital settings. So we undertook a systematic review to look at the types of implementation strategies that have been used to implement screening tools in a hospital previously, and any screening tool that had been used for any clinical condition or symptom in people with cancer were eligible to be included. So this was not specific to nutrition screening tools or sarcopenia screening tools. It was specific to screening tools used in cancer settings. And we then evaluated which implementation strategies were associated with actually being able to achieve implementation outcomes. So adoption of the tool and feasibility of the tool and sustainability of the screening within practice. Of almost 20,000 papers that we screened, 55 publications were included that represented 41 unique studies. And what we did was extract the implementation strategies from these studies, and we grouped them into groups that had used similar types of implementation strategies. And we found 6 different implementation groups that ranged from one-off training sessions, and that was the extent of the implementation process that they undertook, through increasingly intense implementation efforts up to integration of the screening tool within hospital systems and structures and infrastructure, monitoring of the success of the screening process throughout the implementation period and adapting things as needed, as well as tailoring the implementation to barriers that had been addressed before the implementation had started and the resources that were available to service those referrals resulting from the screening within that particular healthcare setting. And not surprisingly, what we found was that the more intense the implementation effort, so that group 6, was the type of implementation strategies that was associated with achieving the implementation outcomes. So we came up with some recommendations as a result of what we found in this systematic review. So some of the key recommendations are really to identify barriers to screening and then design implementation strategies that are tailored to actually address or overcome those barriers. to consider how screening and the referrals that will be generated from screening will be resourced before the implementation begins, and ensure that the resources are in place to be able to do that. And when screening is being conducted by health professionals, we really saw that short screening tools should be considered, just because of the time and resource constraints for health professionals in those busy clinical environments, as well as engaging people with lived experience across all stages of the implementation process. So within our systematic reviews, the studies included very few had actually engaged people with lived experience at all in the implementation process. So in terms of the EPICS program, the next steps, we are actually going through a co-design study at the moment where we have 4 health services involved in the EPICS program, where the screening tool will be embedded in a future trial. We're currently working very closely with those health services to map the workflows for screening for typically malnutrition or other types of screening that are occurring in the cancer population, and trying to align the new process for the EPIC screening tool with the current workflows in those health services, as well as designing referral pathways for patients who are identified as at risk to have access to nutrition and exercise care. What we will then be doing is, early next year, we're undertaking a step wedge trial where we will actually implement the screening tool and those referral pathways into practice at 4 different health services. So 3 health services here in Victoria, including some rural health services and 1 in Queensland. And in that step wedge trial, we'll be really looking at the implementation process, the impact of that screening and referral on the workforce, as well as the cost effectiveness of that tool, and the ability of the tool to actually get people into the services they need to access the care required to reduce their risk of cancer-related muscle loss. And the final step for the EPICS program is to then embed this screening tool into national guidelines. So we'll be updating the Clinical Oncology Society of Australia position statement on cancer-related malnutrition and sarcopenia to include this new tool and the learnings from the trial. So finally, I just wanted to share some quotes with you we've had a number of people with lived experience involved in various steps of this work. So through co-design studies, through the feasibility testing of our screening tool questions. And we've really been overwhelmed with how important this particular topic is to people. And these quotes, I think, really speak for themselves, and something that has really kept us motivated to keep doing the work that we're doing in this area, because I think that the people want to know about this. They want to know about muscle loss and how it can potentially affect them, as well as what they can actually do about it as well. So just in summary, cancer-related muscle loss occurs rapidly and it can lead to dose-limiting treatment toxicities, and it restricts the ability to prescribe optimal treatment, leading to poorer survival. And there's currently no reliable way to screen for people who require further assessment and intervention. So people with low muscle mass are being missed. So our EPICS program will be delivering the first tool to screen for cancer-related muscle loss or low muscle mass globally, and we think that there's potential for national scalability, really leading to optimal cancer care. We have partnerships with rural and specialist health services. So with our Step Wedge trial, we're hoping to achieve some immediate impact on clinical practice by implementing the screening tool and referral pathways within these health services, as well as partnerships with government and professional societies, where we'll see the integration of our work into policy and clinical guidelines. Thank you.
Thank you, Nicole. And of course, it was a very interesting presentation with a lot of information. And yeah, I'm pretty sure it sparked a lot of interest among our clinician and a researcher audience. Just a reminder to everyone that keep your questions rolling in the Q&A section for Nicole. And because I have the opportunity, I'll begin with a question to Nicole. So I know that you talked about a core design process when it comes to understanding the patient perspective of cancer-related sarcopenia. So I would like to hear your thoughts more on what do they think really? Are they aware of a condition as sarcopenia in cancer and its implications? And what is their receptiveness to receive any sort of treatment? Because the cancer patients could be very much overwhelmed with the treatments going on specifically for the disease. So what is their receptiveness to have any exercise or nutrition related interventions? I know it's a lot of questions in one question, so you can take your time.
Yeah, very good question. And I think, as I was saying when I showed you some of the quotes that we've had from people, it's something that's actually we've found to be very important to people. But of course, if they're participating in our study, we're well aware that it's probably the reason they're participating is because it is an important area to them. But certainly, even through other studies and interviews I've done in this space, people might not necessarily be very aware of it before they start treatment, but they're obviously aware of it when it's happening to them, and they don't, I guess, understand exactly what it is that they're experiencing and what they can do about it. So it is certainly something we've found through feedback from people that it is an important thing. It's something they want us to be able to recognise and let them know that is happening to them and help them get access to the care they need to be able to do something about it.
Okay, so on that note, I would also like to ask, what is the current situation? Like, do they really being screened at the moment, or are they getting any treatment, or if it is by referral? So how does it happen in the clinical settings now?
Yeah, so it varies substantially. So in the current COSA position statement, we have suggested people use the SARC-F screening tool, although we know that it's not very sensitive to cancer-related sarcopenia or low muscle mass. So there are health services that have been implementing or using the SARC-F, but it varies considerably, and many health services are not currently screening for this at all, and partially because there isn't an appropriate screening tool at the moment. So there isn't really a systematic way that screening is occurring.
So it is more like in the treatment process or in the any other form of like cancer diagnostic process, if they identify to have low muscle mass, they will be referred for care.
Yeah. Well, I think if someone is noticing that they're weight loss probably, which is often, there's an underlying muscle loss that can occur there. So in that situation, people would be being referred for further assessment and intervention. But I think at the moment, a lot of people are just being missed for this condition.
Yeah, totally understandable. Since we do not have a particular tool. Yeah. Yes, I think we've got a question from Ben. Hi, Ben. Thanks for the wonderful talk, Nicole. Do you think the low sensitivity of SARC-F may be due to the CT measurement of muscle itself when SARC-F is compared to better measure of muscle, example, MRI, which is having high sensitivity? SARC-F also predicts falls and poor problems in heart failure, of course. We know that SARC-F is not a very good tool in many of the settings.
Yes, and that's a very good question because obviously the CT images are looking at abdominal muscle mass, and although studies have shown that that is quite representative of whole body muscle mass, it's not necessarily representing appendicular muscle mass, which I think some of these screening tools, the sorts of questions that they're asking, we do see things like falls and fractures or ability to walk upstairs, for example, that are more representative of arm and muscle strength. So that could be a component to it, but it's also the questions that are being asked. So, we see a lot of younger people going through cancer treatment who a question like, how many times have you fallen in the last year, is not relevant. They're not experiencing falls, but they are still experiencing a rapid muscle loss. So it's probably a combination of both.
Yep. Thanks, Nicole. And we've got another question from Jane. Your comments, please, on the benefits or risks related to muscle loss of an obese patient pre-cancer diagnosis, list undergoing chemotherapy or post-radiation using weight reduction medication, which is a very hot topic now.
Yes, sorry, I missed the first part of that question. Can you just repeat that?
Yeah, so your comments on the benefits or risks related to muscle loss of an obese patient pre-cancer diagnosis, list undergoing chemotherapy or post-radiation, and the patient is also using weight reduction medication.
Yeah, and look, that's obviously a whole new area as well. So we will be looking, as part of the EPIC study, we are going to be looking at the ability of the tool to identify low muscle mass in people who have high adiposity and obesity. And that, I think I mentioned my PhD student, Natalie, and her scoping review. That is going to be one of the studies that she's going to be looking at, whether the screening tool performs well in that particular population as well. In the context of people that are using weight loss medications like GLP-1, that I think is a whole other piece of work and something that we definitely need to be considering. So, obviously we know that alongside that weight loss, muscle loss is occurring. The screening tool that we're developing hasn't specifically been designed intentional weight loss, even though the muscle loss may be unintentional. So it's an area I think that we need to explore, but I don't have a great answer for that one at the moment.
Yeah, that's okay, Nicole. Of course, we are like situations that you're trying to have. I think you may probably have a lot of other questions rolling in, so keep them in the Q&A box. I think Nicole will try to respond to as many as possible during the webinar, but in the interest of time, I think we'll have to move on to the next speaker. I would hand over to Jen to introduce the next speaker today.
Thank you, Ju. I have the pleasure of introducing Dr. Konstantinos Prokopidis, who will be presenting on plasma metabolic signatures and sarcopenia in heart failure. So I'll give you some background about Konstantinos, who recently graduated with a PhD in musculoskeletal biology from the University of Liverpool. Congratulations. And Konstantinos is now a postdoctoral researcher at the University of Glasgow. In his doctoral research focused on plasma metabolite differences in patients with heart failure compared to those without sarcopenia, aiming to identify biomarkers that could be targeted by pharmacological and non-pharmacological interventions. Konstantinos's primary research interests often center on treatments or preventative measures for sarcopenia, cachexia, obesity, and cardiovascular disease. Thank you very much, Konstantinos, for joining us. I know it's very early in the morning and we're looking forward to your presentation. Thank you.
Thank you for the introduction, Jennifer. By the way, you can call me Kostas. That's for everyone. That might be easier, actually. But nevertheless, well, good morning, good afternoon, or even good evening to the attendees. So thanks a lot for the invitation. I'm going to share my screen. Okay, so I'm going to present a little bit of work from some exploratory work we've done during my PhD in Liverpool around plasma metabolomic signatures, of course, as the title says, and particularly around GDF15, that is an emerging marker, especially around not just cachexia, but also sarcopenia in those with heart failure. So initially, what is the main issue here? The impaired cardiac energy metabolism in those with heart failure. So when we have a healthy heart, of course, we have an appropriate function of the electron transport chain to supply ATP for phosphocreatine synthesis, and it seems that there is an equilibrium, there is a balance between energy demands and energy supply from the heart to pump out blood to different tissues and organs. However, when it comes down to heart failure, it seems that this equilibrium is disturbed, and the energy supply is way lower compared to the energy demands. Now, subsequently, that could lead to some changes in some energy substrates, energy sources that could lead to the state. And more specifically, there is a lower branching amino acid oxidation. And although it seems that it has a minor contribution towards cardiac energy metabolism, that primarily these changes occur because of low oxidation of glucose and lactate, whereas these compensates from a greater ketone body oxidation. We know very well that especially glucose is the primary source of our energy, and it seems that patients with heart failure, they do have this problem that they would oxidize greater, more ketones instead of glucose and even lactate. Now, this could lead also to reduced pulmonary reserves, carrying oxygen, carrying capacity, and even peripheral skeletal muscle dysfunction. So, as you can imagine, these people, they do have a greater exercise intolerance, and that could lead to secondary sarcopenia, more sedentary lifestyle, and reduced even functional capacity. Now, if we want to talk mostly about the muscle and what could happen there. Now, a lot of these patients with heart failure, they're characterized by mitochondrial dysfunction in the muscle, greater fat infiltration, not just in the muscle in this patient group, but also in the liver and other organs. They have a greater catabolic cascade, particularly through a greater stimulation of the ubiquitin-proteasome system, and that could lead, obviously, to secondary sarcopenia. But we have to remember that these people, they do develop about 20 to 30% of them cardiac cachexia, and that could lead to greater risk of all-cause mortality. Now, talking about cardiac cachexia, we know very well from people that do suffer from anorexia that there are impaired signaling. It's around the periphery, more specifically GLP-1, CKK, leptin, ghrelin, and even PYY hormones. Now, some of the clinical impact we have seen from multiple systematic reviews and meta-analysis that sarcopenia is linked to lower cardiac function. Now, a good cardiac function marker in this population group would be the natriuretic peptide. So here we talk about the B-type natriuretic peptide and even its N-terminal fragment. That would be NT-proBNP. Higher levels of natriuretic peptides are linked to greater levels of inflammation, so C-reactive protein, as well as high levels of malnutrition. Sarcopenia is linked to greater risk of malnutrition and greater mortality. Now, these people with heart failure, they would have cardiorenal metabolic syndrome. So some of these people, they would have diabetes. So there is a greater link of malnutrition there as well, and greater mortality risk. And eventually, both sarcopenia and cachexia, they are linked to a much greater risk of all-cause mortality in heart failure. We also thought it would be a good idea to see what happens at the muscle level. So we gathered data from 35 studies in people with mean age of approximately 60 years. So we had a group with heart failure patients and a control group with healthy volunteers. So what we found at the muscle level was that those with heart failure from vessels lateralis, actually biopsies, have reduced capillaries for type 2A and type 2X fibers, lower levels of IGF-1, higher levels of myostatin, and even lower levels of some of the energy substrates for phosphocreatine synthesis, including citrate synthase and succinate dehydrogenase. So it seems that those, just for an introduction, it seems that those with heart failure do have impaired muscle health and even cardiac energy metabolism, of course, that could lead to secondary sarcopenia. So that would beg the question whether we could find biomarkers to counteract sarcopenia or reduce muscle health in this clinical population. So initially, we wanted to see whether it could be feasible and whether people with heart failure would be okay overall to undergo some sarcopenia assessments, then compare some clinical biological data in those that do have reduced and preserved muscle health, with the final aim to see whether we could establish in the future a heart failure sarcopenia phenotype. So we recruited people with heart failure, diagnosed with heart failure, irrespective of ejection fraction, whether that would be reduced or preserved ejection fraction, with a minimum age of 50. So we'd have a first group of those with reduced muscle health, preserved muscle health, and a control group of healthy individuals. Now you might wonder how we can define reduced muscle health. In this case, we used, based on the European Working Group guidelines, either a low grip strength or a low 30-second chair rising test with low physical activity levels. Now, in relation to the procedures, we run some DEXA scans for good body composition, grip strength and knee extension strength for the strength tests, and some near-infrared spectroscopy for nerve function in the forearm muscles. In terms of physical performance, we collected data from timed up and go test, gait speed, 30-second chair rising test, and 6-minute walking distance. Some confounders that we collected data from, that would be dietary intake, sleep quality, physical activity, quality of life through the Sarcopenia questionnaire, and medication history. And eventually we did collect some blood and fecal samples from each participant. Now, some of the exploratory findings around the gut microbiota autoregulating mitochondrial metabolites and GDF15 here, but this is not about sarcopenia, but this is purely based on heart failure versus the healthy volunteers. We found that those with heart failure do exhibit high levels of GDF15 as well as TNF alpha. Now, those with higher levels of GDF15, they do exhibit a lower score of ALSTI to be normalized to BMI. So that would be appendicular lean soft tissue index normalized to body mass index. And interestingly, it seems that those with higher GDF15 levels do exhibit higher total fat mass as well. Now, in regards to some of the results, it seems that GDF15 is associated with high levels of pyruvic acid as well as fumaric acid in those with heart failure, although even those healthy volunteers that do have higher levels of pyruvic acid. In addition, in terms of the fat mass associations, we thought it would be a good idea to have a look at some of the gut-related metabolites. However, we didn't really find for the majority of them any associations with fat mass. However, it seems that hypuric acid was negatively associated with fat mass in just those with heart failure. Now, some unpublished data here around the link of malnutrition with sarcopenia measures and even GDF15. We ran some correlations first, and we found some moderately positive correlations between some nutritional status that would be through mini nutritional assessment, so MNA, with grip strength as well as grip strength normalized to BMI, whereas we didn't find any significant correlations with ALSTI and ALSTI normalized to BMI. We also thought it would be a good idea to have a look at the Sarcopenia questionnaire that is a bit underexplored, especially in this population group, and it's obviously relatively new. We found some positive correlations here with grip strength, particularly grip strength normalized to BMI, and malnutrition with Sarcopenia questionnaire, but we did find a correlation with ALSTI or ALSTI normalized to BMI. Now, regarding some of the metabolites, it seems that those with a lower MNA score, so 0 to 11 would indicate malnutrition risk. They do have high levels of GDF15 compared to those with a greater nutritional status. However, in relation to myostatin, activin A, and follistatin 3, we do not find any differences between the groups. Some other more recent work around the plasma metabolomic signatures. So we took two groups here. So the first group would be those with heart failure and preserved muscle muscle health, and those with heart failure with reduced muscle health. So as you can see here, those with reduced muscle health, they do have already lower levels of moderate physical activity. In terms of the raw values, even vigorous physical activity was lower. The intensity through the MET score is lower, as well as MNA, and well, subsequently, as you can see, the Sarcov questionnaire and SARCOR, they are seems that they are lower in those with reduced muscle health. In terms of body composition, they had relatively the same absolute fat-free fat-free mass, and even appendicular and lean soft tissue. Whereas those with reduced muscle health, they did have considerably lower levels of body fat, although most of the sarcopenia-related markers were quite impaired, obviously compared to those with preserved muscle health. As far as how we defined them. Now, in terms of some of the results, in regards to some of these metabolites, we found that GDF-15 was high in those with reduced muscle health compared to those with preserved muscle health, whereas also NT-proBNP did show some trend in terms of being higher, so that would indicate greater or impaired cardiac function. TNF-alpha, activin A, follistatin 3, they were quite similar between the two groups. And eventually, HOMA-IR index, that was quite higher in those with reduced muscle health compared to those with preserved muscle health. So that would indicate a greater risk of insulin resistance. Now, we run some PSA analysis through GCMS, so some mass spectroscopy. We found in those that with reduced versus preserved muscle health that glutamine, pyruvic acid, even glutaric acid, they were upregulated in those with reduced muscle health. Well, I'm assuming that could be some type of explanation around energy compensation with higher plasma levels of these metabolites, whereas some well-known metabolites or proteins, including valine, isoleucine, and even phenylalanine, and even glutamic acid, actually, that were downregulated in those with reduced muscle health. Some of the outcomes and future directions around this area with our work and what we have collected would be the analysis of fecal samples and see whether we would have different concentrations of short chain fatty acids in those with preserved versus reduced muscle health, and whether the gut microbiome environment would be distinct in this population group. Obviously, that would be something maybe we could look at in the future, maybe, I don't know, maybe the next 5-10 years, whether we could target actually these biomarkers with interventions. And at the end of the day, what do we want as all healthcare professionals and scientists to reduce the impact of sarcopenia, not obviously in just heart failure, but overall. I will share now some future directions around the field of sarcopenia and heart failure. Of course, that's not just applicable for heart failure, but overall for the field of sarcopenia. So first of all, whether nutritional interventions could be affected actually by sarcopenia status. Some people I know, a lot of you work around resistance exercise and even other types of exercise. So that would be an interesting question as well. Well, in terms of, again, heart failure, which phenotype gets benefited more? Could it be that those with heart failure and reduced ejection fraction get benefited more compared to those with a preserved ejection fraction? What about outside of metabolomic signatures, but what about proteomics in those with versus without sarcopenia heart failure? And since those with HFpEF, they are defined to a great extent by those that do have type 2 diabetes and even obesity. Could it be that sarcopenia and obesity actually affect those with preserved ejection fraction more than those with reduced ejection fraction? I think it would be a good idea to also highlight some of the GLP-1 related topic here. So I think this is a very hot topic, actually very emerging as well. And a lot of people with heart failure, especially those obviously with obesity, they do get prescribed GLP-1 receptor agonists and even now a dual agonist with GIP. So it seems that although we know that appendicular lean soft tissue could be preserved, or the losses might not be that much actually, and even physical function could be improved to a small extent. We don't really have a lot of data. That's not just for heart failure, but I would say overall around, well, longer term losses of muscle strength, And of course, we have to be aware of any long-term prescription for weight cycling going on and off. There's medications that could lead to a gradual increase in sarcopenic obesity. Well, of course, this is speculation, but I think it's a valid concern for at least for this population. So that was the presentation. Thank you very much. Thank you for the invitation. And yeah, looking forward to any questions.
Thank you, Cos. That was an excellent presentation. Really appreciate it. Very interesting, very thought-provoking, and so much research that you've been doing, and so impressive. I will give our attendees a moment to post their questions in the Q&A function. So in the Q&A function, you can post your questions for Cos. And while people are thinking about those questions, I do have a question for you.
Yeah.
It sounds like from the work that you've been doing that you're getting closer and closer to characterizing a phenotype from a number of different biomarkers for people with sarcopenia who have heart failure. Could you elaborate on more about how that profile is shaping and how you could see the directions for clinical practice in terms of what interventions might be used to target that, whether it be pharmacological or non-pharmacological?
Yes, well, thanks a lot for the question. I think, well, first of all, that was an exploratory study. We had just 25 people for, at least for this part of my work. We would need definitely more people, so we can have a greater ratio of those with sarcopenia versus without sarcopenia, because how we define here, reduced and preserved muscle health, is certainly not really sarcopenia, but mostly I would say a proxy. Now, we have to be aware as well that those with heart failure and preserved versus reduced ejection fraction, they do have distinct profiles regarding sarcopenia and even obesity. So you can imagine that would be a different prevalence and overlap of sarcopenic obesity and how that could affect metabolomic signatures. Now, in terms of interventions, we don't really have a lot of data around protein supplementation, actually. There are a couple of systematic reviews and meta-analysis, but they usually synthesize very different dosages of particularly whey protein, but they could throw in some essential amino acids as well, and high protein diet. So we don't really know a lot of how not just whey protein, but protein supplementation overall would do in terms of muscle health in this population group. And now in regards to exercise, and I would mention mostly actually resistance exercise, because it's more applicable to obviously muscle hypertrophy and strength gains. We have to be very careful with some of these people, because it might not be feasible to even do some of that resistance exercise. And we know very well that resistance exercise, it is a word, but we have to be aware of the volume and the intensity and the frequency of our particular type of exercise. So that would be, I would say, another open maybe idea for pharmaceutical companies around some of the sarcopenia-related drugs that might be emerging, but we don't really have strong drugs, I would say, at the moment.
Excellent. That's great. And like we say, like exercise being prescribed like a drug, finding the right dose, and how important that research is beyond the blanket prescription of resistance exercise. That's an excellent point that you raise. And then also thinking about how we do that in conjunction with appropriate nutrition to optimize those benefits. That's an excellent point that you raised there, and really interesting research, really at the cutting edge. So it sounds like with more data, we'll be able to unpack more insights, which will be really useful. That's excellent. In terms of any questions for Cos, I've double-checked the chat, and there's also, I haven't seen any come through just yet in the Q&A. People may be writing their question as we've been speaking. I'll open up to the panelists if there's any other questions from the panelists who might like to raise a question before we hear from the audience.
I've got a question, actually,
Great.
for Con, if he doesn't mind. Excellent presentation there, Con. Thank you. I'm just wondering, in your view, how stable might these metabolomic signatures be over time? Are we looking at a snapshot of their biology or something that can track disease progression?
Thanks a lot. Absolutely, we do need some longitudinal data here. Um, Obviously, because of PhD is, like a limited duration, we could not really do this. But I think what's more interesting about your question is about the disease progression, whether that would overlap with sarcopenia profile. I'm not aware of any work around this field, and I would say we were the first ones that tried to attempt to answer this question, at least cross-sectionally. But yeah, I mean, since we have some data that sarcopenia is linked to impaired cardiac function, especially measuring it through BNP and NT-proBNP, we can make some speculation that, well, the greater the sarcopenia duration is actually the disease progression is going to be high as well. But as far as I'm aware, in the literature, and there is no availability of evidence, so I can't really tell you for sure that hey, this happens. But that could be a good idea for future work, some longitudinal trajectories around this field.
It certainly is an emerging and exciting space, and you're really pioneering that. So that's excellent to hear from you. Thank you, Cos. I will I'll keep monitoring the Q&A function, and I'll let you know, Cos, if anything comes
Yeah.
up for you further in the chat or the Q&A function at this stage. But what I will do now is I will hand to Dr. David Berry to introduce our next speaker.
Hello, everyone. Thank you so much. Great presentation so far. I've got the pleasure of introducing our third and final speaker for this afternoon or for this morning, depending on where you're dialing in from around the world. I believe he's in the panel group here today. Good. Andrea Ticinesi is Associate Professor of Internal Medicine with the Department of Medical Sciences at the University of Ferrara. He graduated in medicine and surgery from the University of Parma, subsequently specializing in internal medicine before completing a PhD in medical sciences. He has authored over 170 peer-reviewed publications, which have received over 7,100 citations. In 2017, he was among the first researchers to propose the existence of a gut-muscle axis, linking gut microbiome composition with the pathophysiology of sarcopenia in older individuals. Today, he'll share the latest developments in this exciting and rapidly evolving field. Over to you, Andrea.
Good morning and good afternoon to everyone, depending on where you are. And thank you, David, for your kind introduction. So I will try to share my screen. Okay, so I hope you can see my presentation. Okay. So in this talk, I will try to give you an overview of the relationship between gut microbiome and aging, and particularly how gut microbiome can be related to the aging trajectories, at least according to the most cutting-edge evidence. And then I will give you a focus on the gut muscle axis and on its relevance for the pathophysiology of age-related sarcopenia. So we all know that the gut microbiome represents a community of microorganisms symbiotically living with the host in the gut lumen, and mainly composed of bacteria, but there are also data about the gut virome and the gut microbiome that will not be the object of my presentation. The fecal microbiome is generally assumed to be representative of the mucosal-associated microbiome, although there is no complete overlap, and we must bear in mind this important concept. The Bornand approach to fecal microbiome analysis is based on bacterial DNA sequencing, so the current gold standard is represented by shotgun metagenomics. And these techniques have allowed us to understand that in each fecal sample from human beings are harbored from 1,000 to 4,000 different bacterial taxa, most of which cannot be cultivated with classical microbiological techniques. And so one distinctive feature of the human gut microbiome is its biodiversity. There are a few species that are highly represented in absolute terms, such as Bacteroides, Prevotella, and Alistipes, but there is also a large number of minor players that show lower representation in absolute terms, but relevant metabolic activity, such as, for example, Faecalibacterium, Butyrivibrio, and Succinivibrio, which are very important bacterial species because they have the capacity of producing short-chain fatty acids, which represent very important mediators that exert beneficial actions for the host physiology. The gut microbiome of healthy adults also shows stability over time and resilience to transient perturbations, so that if we administer a short course of antibiotic treatment to a healthy individual, of course, the gut microbiome is affected in the short term, but then after stopping the antibiotic treatment, the gut microbiome tends to return to the baseline state. And another fundamental characteristic of the human gut microbiome is its huge inter-individual variability. There are many factors that shape the gut microbiome composition at the individual level, and they are mainly environmental factors. And the first ones are surely diet, physical exercise, but also social networks, cohabitation with pets, and exposure to green space or pollution. And the sum of all these environmental exposures contributes to explain the huge inter-individual variability of gut microbiome composition. So if we compare the gut microbiome between individuals who belong to two different populations with different habits, we will find very important differences. But the differences are significant also when we compare the gut microbiome composition between two individuals who belong to the same population and who share the same lifestyle and habits. The gut microbiome remains relatively stable during adulthood and shows, as we have just said, a huge inter-individual variability. This variability is in some way emphasized in the older age, and after the age of 60, the gut microbiome of all human individuals faces some sort of reconfiguration towards dysbiosis. So there is a tendency towards an imbalance between bacteria with purported health-promoting activity and bacteria who represent opportunistic pathogens. And so in the older age, the gut microbiome is characterized by reduced biodiversity, so reduced absolute number of bacterial species that can be detected in fecal samples, reduced resilience to stressors, and increased representation of opportunistic pathogens. And the main drivers of these age-related changes in gut microbiome composition may be found in the cellular senescence at the gastrointestinal level. In fact, senescence of the gut mucosa is associated with reduced secretion of mucus, reduced synthesis of mucosal immunoglobulins, and reduced release of antimicrobial peptides. And all these elements contribute to redefine the equilibrium between gut bacterial communities who live in the gut lumen and the defensive pathways that are expressed in the gastrointestinal mucosa. And so the consequence of this imbalance is an increase in gut mucosal permeability that allows the entry into systemic circulation of bacterial byproducts and of bacterial toxins that provide a continuous antigenic stimulation to the host immune system. And this ultimately leads to a continuous inflammatory stimulus that contributes to increased vulnerability to illness and to stressors. And recent evidence emphasizes the role of intestinal T-cell senescence in this process, because these cells with aging become in some way less effective to control the proliferation of opportunistic pathogens at the gastrointestinal level. And on the other side, these T cells become tonically activated. So they continuously release pro-inflammatory cytokines that sustain alterations in gut mucosa permeability and lead to the phenomenon, which is a very important pathophysiological phenomenon of aging, which is called inflammaging. Inflammaging is a chronic state of subclinical activation of the inflammatory response and is the result of multiple external and internal exposures, which gut microbiome is only one element, but of course a fundamental element driving the activation of the inflammatory response. Inflammaging is a universal phenomenon. We can see inflammaging in each individual, in each organism, not only human beings who age. And inflammaging, if not controlled by adaptive systems, can lead to clinically relevant outcomes in terms of chronic disease burden, reduced function, and risk of acute illness. And inflammaging is activated by the sum of the environmental and antigenic stimulations on the immune system that occurred during the entire lifetime. This is an important concept that Professor Claudio Franceschi has operationalized, defined as immunobiography. Immunobiography is not only the sum of all the infections that each individual who age has experienced during his entire lifetime, but it is also the sum of antigenic exposures resulting from gut microbiome. And of course, the age-related gut microbiome dysbiosis provides an enormous amount of antigenic stimulation, activating innate immunity and adaptive immunity, which ultimately results into inflammaging. The way inflammaging expresses itself in each individual depends on how the biology of each individual is able to cope with this chronic activation of the inflammatory response. Some individuals may develop some strategies to counteract inflammaging, and so they may have an aging trajectory towards fitness and longevity. On the other side, many other individuals may be unable to cope with inflammaging, and so they may develop frailty and age-related chronic conditions. So the relationship between the gut microbiome and frailty is particularly important, not only in biological terms, but it may be important also in clinical terms. Many studies have explored this possible association, and here you can find a summary of the main results of one study, which in my opinion is the best one, the largest and most elegant one, that was published by a Chinese group in Nature Aging in 2023. And these researchers were able to demonstrate that the abundance of a limited number of bacterial taxa in fecal samples of older Chinese individuals was correlated with increased frailty burden. And they also developed an advanced frailty index that embedded not only traditional clinical measures of frailty, but also some omics outputs. So they included into this frailty index fecal microbiome parameters and blood metabolome parameters. And they demonstrated that this updated frailty index outperformed traditional clinical tools in prediction, not only of frailty status, but also of survival. And they demonstrated these results in the study cohort and also in a separate validation cohort. And so this is probably the most important and most elegant demonstration that gut microbiome composition may really predict the prognosis of older individuals and be associated with gene trajectory. And related to this topic, we may also ask ourselves whether centenarians and supercentenarians, so individuals who reach extreme longevity, may have different gut microbiome composition and different biological features than older individuals who do not reach these extreme ages. And the studies demonstrated that centenarians are not characterized by an absence of gut microbiome dysbiosis or reduced inflammaging. In fact, dysbiosis is very pronounced in the fecal microbiome of these subjects, and inflammaging is well expressed also in centenarians and supercentenarians. But these individuals show an exceptional adaptation to these alterations. In the panel below, in the lower part of the slide, you can see a summary of the gut microbiome composition of a single individual. It was a woman that was 116 years old. And this woman had features of extreme dysbiosis in her gut microbiome, but also expressed an exceptionally high level of bacteria that exert anti-inflammatory properties, for example, Bifidobacterium and Subdoligranulum. So we may affirm that longevity is associated with the same biological mechanisms seen in non-longevous older people, but the distinctive feature of longevity is the capacity to express adaptive systems at the gut microbiome level and also at the inflammation level. So inflammaging in these individuals is counterbalanced by production of anti-inflammatory cytokines. So there is some sort of adaptation to inflammaging. The way gut microbiome influences aging is not only in prolonging lifespan, but also influencing organ aging. So influencing the pathology and the pathophysiology of several organs that are far away from the gastrointestinal system. And so there is a large body of evidence coming from animal studies that demonstrated that the gut microbiome is able to influence the brain pathology, particularly the onset of major neurocognitive disorder. And so there is really a gut-brain axis. There are evidence demonstrated that the gut microbiome is able to influence kidney function, so the gut-kidney axis. And recently, there is also much evidence suggesting that the gut is able to regulate the balance between synthesis of bone and bone resorption, and so is able to regulate osteoporosis in the so-called gut-bone axis. And of course, there is also a gut-muscle axis, so the gut microbiome is able to influence skeletal muscle health. Some years ago, about a decade ago, we asked ourselves whether gut microbiome could be the mediator of the effects of diet and lifestyle, particularly of physical exercise, on skeletal muscle health. And we wondered whether the gut microbiome could be pathophysiologically involved in contributing to the onset of age-related sarcopenia. And these hypotheses were further confirmed by a large body of literature that was produced from animal studies and then also from some human studies. And so nowadays we can affirm that the gut microbiome dysbiosis is able to influence the onset of sarcopenia, for example, through mediation of increased permeability of gut mucosa that stimulates increased inflammation, which of course is one of the major determinants of anabolic resistance in the skeletal muscle. Gut microbiome dysbiosis is also associated with reduced representation of bacteria able to produce short-chain fatty acids. And these mediators, such as butyrate, acetate, and propionate, have positive functions on skeletal muscle, and particularly they stimulate skeletal muscle protein synthesis. And so the shortage of these mediators can be detrimental and favor the onset of sarcopenia. Animal studies also demonstrated that gut microbiome dysbiosis is associated with reduced macronutrient digestion and reduced synthesis of vitamin B12 and folic acid that are very important for stimulating muscle protein synthesis. And so also recent evidence has proposed many different mechanisms that may be involved in the gut muscle axis. For example, there is evidence that the gut microbiome is able to influence tryptophan metabolism, which modulates muscle protein synthesis. And there is also evidence that gut microbiome dysbiosis is able to down-regulate mitochondrial biogenesis and activation in skeletal muscle cells. Another important issue is the capacity of gut microbiome to biotransform some compounds that are present in healthy diets into metabolically active mediators. Here you can see just an example, the capacity of gut microbiome to biotransform polyphenolic compounds named elagitannins into bioactive mediators such as urolithin A. Urolithin A is a compound with demonstrated positive modulation of lower limb muscle strength and power. Unfortunately, in older individuals, the gut microbiome tends to lose these functionalities, and the dysbiosis is often associated with the metabotype B, leading to the synthesis of mediators that have no known effects on muscle health. And so the intake of polyphenolic compounds in older individuals may be ineffective at the skeletal muscle level because there is a lack of specific functionalities in the gut microbiome that activate these compounds. The evidence on the relevance of the gut muscle axis has been strengthened by transplantation studies, and particularly transplantation of microbiome from failed sarcopenic older men to mice resulted into worse measures of skeletal muscle performance than transplantation of microbiome from fit older men to mice. And so this is probably the best demonstration of the real existence of a gut muscle axis in mammals. Of course, these kind of studies cannot be performed fully in human beings, but their pathophysiological relevance is much evident. There are also many research groups that have tried to compare the gut microbiome composition between older sarcopenic individuals and age-matched controls. And for example, in this study, the researchers found that fit older subjects exhibited higher microbiome representation of Prevotella, Faecalibacterium, and Barnesiella, and lower representation of opportunistic pathogens. In another study conducted in Italy, subjects with physical frailty and sarcopenia had reduced biodiversity and increased representation of bacteria like Eggerichia, Veillonella, and Enterococcus in comparison with age-matched controls. While in the largest study to date performed on this topic with a case control design, a Chinese group demonstrated that the probable biomarkers of sarcopenia were Disulfovibrio piger, Clostridium symbiosum, Bacteroides fluxus, and so on. So, as you can see from this overview of studies, the gut microbiome of older sarcopenic individuals is indeed different in its composition than the gut microbiome of controls. But the bacterial taxa significantly more represented in sarcopenic older individuals and in controls show marked heterogeneity across studies. And also the bacterial taxa associated with diagnostic parameters of sarcopenia, such as measures of muscle mass, strength, and function, are also widely heterogeneous across studies. And these assumptions have been well demonstrated by a recent systematic review with meta-analysis published by a Chinese group. So if the gut microbiome is pathophysiologically involved in the onset of sarcopenia, we may ask ourselves whether targeting, developing some therapeutical options centered on the gut microbiome may be effective to counteract sarcopenia. And so promoting healthy diet or administering probiotics or prebiotics could be an effective strategy to reduce the burden of sarcopenia in older individuals. Well, the healthy diet paradigm that has very modulatory capacity on the gut microbiome composition is represented by the Mediterranean diet. And in this field, there is a very important study, which is the New Age study, a randomized controlled trial conducted across 7 European countries on 612 subjects that were randomized to receive a Mediterranean-style diet tailored to older people or their usual diet. And the researchers were able to demonstrate an association between a score expressing the overall abundance of diet-responsive microbial taxa and clinical parameters of sarcopenia and frailty after 1 year intervention. So this data suggests that the gut microbiome, modulating the gut microbiome with diet, has also a potential to improve skeletal muscle function parameters. But specific studies on the field or in the field of sarcopenia are still lacking. Then, of course, we may modify the gut microbiome composition by administering probiotics. And here you can see a systematic review with meta-analysis of intervention studies that we published some years ago. And we found that the effects on muscle mass and strength were observed only when a few bacterial strains were administered to human beings, and particularly Bifidobacterium, which shows the best potential to modulate skeletal muscle mass and strength. But we also found that the effects of probiotics on muscle mass and strength were less pronounced for participants aged more than 70 years old. And we must bear in mind this issue because the gut microbiome composition of older individuals suffers from a huge inter-individual variability. And so the effectiveness of probiotics may be reduced in this population. We must also acknowledge that these studies were too short to observe long-term effects on parameters related to sarcopenia, because most of the existing studies had a follow-up period of just 12 weeks, which of course is a too short period to observe improvements in a chronic conditions like sarcopenia is. So in conclusion, we have seen that the gut microbiome represents a fundamental hallmark of aging, and we have seen that longevity is associated with adaptation to negative consequences of dysbiosis. We have seen that the aging gut microbiome influences organ-specific aging and illness, and this is true also for muscle health. And so the gut microbiome may be pathophysiologically involved in the onset of age-related sarcopenia. But despite the evidence from animal studies, research on the role of gut microbiome in human sarcopenia is still inconclusive, because to date we have no shared microbial biomarkers of sarcopenia in human beings. However, we must continue to do research in this field, and we must bear in mind that the gut microbiome in older individuals is highly individualized in its composition. And so we must conduct research in this field, bearing in mind the principles of personalized medicine. And I hope that in the future, gut microbiome science will enter much more into the clinical practice in geriatric medicine. So I thank you very much for your kind attention.
That was amazing. Thank you so much, Andrea. There's a lot to unpack and compress there. If any of our attendees have some questions for Andrea, please just pop them into the Q&A feature below, and we'll try to read them out as we go. I've got so many questions here for you. While we're waiting for questions to come through, I might toss a couple to you here. It seems that the gut microbiome might help explain why some people age with remarkable resilience, while others might follow a trajectory towards frailty and sarcopenia. I particularly liked your point earlier of the differences, the microbiome inter-individual differences that might explain the biotransformation of those compounds that ultimately are the postbiotics. Do you think that there is a place for that in clinical science, for trying to determine whether people are responding or non-responding to certain dietary interventions that might have impact on these physical performance outcomes?
Well, I think that the gut microbiome may be important to determine the responsiveness to intervention and the variability to responsiveness. In the New Age study, Mediterranean diet was demonstrated as effective in counteracting frailty, in improving cognitive outcomes, for example. And this was the average result. But even in the intervention group, there were some individuals who did not respond to Mediterranean diet. Some individuals even had worse outcomes after initiating Mediterranean diet. And so maybe the gut microbiome is involved in explaining why there is there is a huge variability in responses in older individuals.
I think I saw a question come through in the chat feature there from Lakshmi, asking, does fasting help to improve gut microbiome?
Well, there probably fasting is able to modulate the gut microbiome composition. We still have no conclusive data on older individuals, but there are some, I would say, seminal evidence. There is some seminal evidence that suggests that intermittent fasting may induce favorable changes in gut microbiome composition, and so it may be effective in improving health-related outcomes in older individuals. But of course, even in this case, there is an elevated inter-individual variability in responses.
Excellent. Thanks for that response. While folks are probably trying to compose their questions and type them in here for us, I can throw a couple more to you here. I just found it so riveting here, and particularly in your mention of immunobiography and viral biography, sort of some cumulative exposure of the individual's environment to, not necessarily toxins, but just environmental exposures that could influence the microbial profiles with its subsequent effects on the various axes related to the microbiome. I just found that really quite fascinating, particularly in view of some of the other sessions that we've heard about, listened to today. We've heard today about cancer-related sarcopenia, heart failure-associated sarcopenia, and now, of course, the gut-muscle axis as well. Do you think these conditions share common biological pathways, or are we dealing with fundamentally different forms of muscle loss?
Well, some of the pathways are certainly in common. For example, the role of inflammation, inflammaging, and inflammation related to acute infection and to chronic infection, of course, may be important across all these conditions. And of course, you mentioned the immunobiography. Immunobiography is able to also explain the huge variability in gut microbiome composition, because, of course, each of us has a different background of exposures across his entire lifespan. And so I think that we must put microbiome research into a wider context, and we must consider also events that occurred in earlier life to explain how the microbiome ages and how the phenotypes of aging develop.
Fully agree. It seems that's a common theme that's come up in each of the presentations today, is sort of the need for, or the lack of, longitudinal data over time, particularly if we're viewing muscle impairment and, sarcopenia as not necessarily an age-related condition anymore, because we're seeing it in younger and younger populations. I think it'd be very fascinating to find microbiome profiles in people in their 20s and 30s and 40s and see how that might lead to changes over time. There's a couple more questions to come through here. I know we're really pushing for time, but I thought I'd read these out. From Parastu, is there any evidence that improving muscle mass can improve the gut microbiome, particularly in older individuals? Thank you for the program.
Okay. Well, I would say that this is a great question. Of course, there is evidence that the gut microbiome is positively modulated by physical exercise. And so at the current state of the art, we know that the gold standard for treating sarcopenia is improving physical activity within a multi-component intervention framework. But physical activity, of course, is a pillar of the treatment of sarcopenia. And so there is also evidence that physical activity is a powerful positive modulator on gut microbiome. So we can assume that improving physical activity in older individuals has beneficial effects on the gut microbiome composition. But at the moment, there are no studies that have explored this point.
Perfect. Thank you so much for those responses. I think, in the interest of time, we might ask Andrea to field responses in the Q&A chat here, but we might close the session down here, just in honor of everyone's time. Thank you so much, Andrea, and thank you to all of our speakers today. You're very welcome, of course. I want to acknowledge also the earlier sessions from Nicole Kiss and, of course, Konstantinos Prokopidis for these outstanding presentations. On behalf of the Australian and New Zealand Society for Sarcopenia and Frailty Research, I'd like to sincerely thank all of you for sharing your expertise and insights with us, and to everyone who joined us online from Australia, New Zealand, and around the world. Today's presentations have highlighted just how rapidly the field is evolving. We've heard about advances in cancer-related sarcopenia care, exciting developments in metabolomics, and the emerging role of the gut microbiome in healthy aging. While these topics are diverse, they all point towards the same goal, moving beyond simply recognizing sarcopenia to implementing effective, evidence-based strategies that can improve health outcomes for older people. World Sarcopenia Day is an important opportunity to raise awareness of this condition, but it's also a reminder that collaboration across disciplines is essential. It is only by bringing together clinicians, researchers, and allied health professionals, as well as consumers, that we will continue to advance the field. Thank you again to our speakers for generously giving their time, especially Konstantinos and Andrea for joining us at such an early hour from the UK and Italy, and thank you to everyone who helped organize today's webinar. If you're interested in supporting this work, we warmly encourage you to consider becoming a member of the Australian and New Zealand Society for Sarcopenia and Frailty Research. Membership helps support the Society's activities, including initiatives like today's webinar, and contributes to advancing sarcopenia and frailty research, education, and collaboration across the globe. We hope you found today's session informative and inspiring. We look forward to seeing many of you at future ANZ SSFR events. Thank you all, and enjoy the rest of your day.